Okay, let's go ahead and get started. I'm sure people will continue to trickle in. Traffic was pretty bad on 71. So today's topic, I think, should be something of interest to everybody in this room. MS is certainly not a rare diagnosis. There have been lots of well-known celebrities who have MS. Joan Didion, um, uh, Terry Garr, Ozzy Osbourne's son. And for those of us who are old enough to remember the Mickey Mouse show, Annette Funicello actually had MS as well. So I am pleased today to introduce our speaker who's going to come give us an update. Dr. Robertson from the Department of Neurology did his undergraduate training in Kansas and then did his postgraduate medical training at Vanderbilt, both his internship in internal medicine and his neurology residency. He subsequently went to IU, was there for a number of years, and then we were fortunate enough to be able to recruit him here in 2015. He's had an ongoing interest in MS. He is the medical director of our MS clinic, also has significant experience in treating patients who have traumatic head injury. So with that, welcome to Medicine Grand Rounds. Look forward to your talk.
Thank you. Well, good morning. Make sure this is on. Are we okay? Is it too loud? So thank you for having me. I haven't been in this environment before. You guys are welcome to interrupt. You're welcome to raise your hand, yell at me. I actually prefer a discussion versus a lecture. I'm not sure how formal this is, but if something's going on, you want clarification, just yell at me and interrupt. So I do have disclosures. I speak for Biogen and Sanofi Genzyme. I'm going to use branded names because there's so many monoclonal antibodies. It's messy and my tongue gets tied. Copaxone and glutiramer. Glutiramer acetate is our only generic. So I prefer to use branded names. So I apologize for that, but it works way better. And depending on our discussion, I may mention stem cell therapy as a treatment for multiple sclerosis. It's currently not FDA approved, but it's a really interesting part of multiple sclerosis. So this is not a talk about what multiple sclerosis is. Again, recognizing the crowd, it's a medicine crowd primarily. Everybody's welcome. But this is not a talk on multiple sclerosis. It's obviously part of it. But if you want to learn more about multiple sclerosis, come hang out with us down the hall from your department. This is a good time for us to do this talk because the hospital has created a multiple sclerosis clinic under the hospital's umbrella. We actually had a lot of help from some of our peers. So we have dedicated space, and hopefully we're going to dedicate more resources to the clinic and kind of see what happens. So we're up and running. We're trying to do some new things. We're trying to add resources to our clinic. So your support is certainly welcome. So this is the only slide on what is multiple sclerosis. Really, we don't know. We know that there's an immune component of the disease. The dogma has been that it's a inflammatory demyelination is probably the driving force. But there is plenty of degenerative axonal involvement in multiple sclerosis that really has been appreciated more in the last decade. So our treatments are all anti-inflammatory. They're all immune system modulators. And we're not really talking about the efficacy of treatments until a little bit later. So our treatments work, but all of our treatments are imperfect. We aren't fixing the problem. Many of our patients that seem like they're doing well eventually still accumulate significant levels of disability, cognitive disability, as they live with this disease. So in multiple sclerosis, we're missing something. There's people working really hard. It does behave sometimes as a degenerative disease rather than this inflammatory relapsing disease. Our treatments are effective and have changed how our patients with multiple sclerosis age, but our treatments are incompletely effective at this point. And there's a lot of people working very hard on it. Just like many autoimmune diseases, although we don't know that multiple sclerosis is purely autoimmune, we think that it's a genetically primed individual that has environmental triggers. And I think that's a good explanation for a lot of rheumatologic disease, autoimmune disease, and it's still where we are in the multiple sclerosis field. Just to get you thinking a little bit, here's an example. So if you see a 28-year-old female with difficulty walking, numbness up to her chest, she comes into your office, and you get a history that 2-3 years ago she had visual loss in one eye, What's the diagnosis? Most likely, it's multiple sclerosis. Think about what tests you might do as an internist, because these people more often present to internal medicine or the primary care physician. What tests might you order? And how do we come to the diagnosis? There's no single way to diagnose multiple sclerosis, which is why it takes a pretty good history, a detailed exam, and a constellation of tests to get to the diagnosis. That's kind of the work that we do. This slide summarizes multiple sclerosis. It's a really busy slide. I point out a few things on this, so I want you to engage with the slide for a minute. So across the top, RIS, CIS, the diagnosis of relapsing remitting multiple sclerosis, and then a transitional phase that we don't understand very well, and then ending in secondary progressive multiple sclerosis. So RIS is radiologically isolated syndrome. So we're getting pictures on people that have traumatic brain injuries. You get a CT scan, get an MRI. It looks like multiple sclerosis. If their life has been cruising, nothing has happened. We don't know how to handle those situations. Clinically isolated syndrome, or CIS, is when somebody has their first neurological event. Optic neuritis, weakness or numbness of an arm, and then you do an MRI scan, and you see all kinds of changes, but they've only had their one clinical event. If they have their second clinical event, it's relapsing remitting multiple sclerosis. The next part of this I want you to pay attention to is the red line. The red line is probably the driver of pathology. It's inflammation. It's the immune system learning bad habits, getting into the brain, targeting something we don't know for sure, seems to be associated with myelin, and causing damage to brain and spinal cord. This is where we're getting most of the disability, most of the early changes. But people aren't diagnosed until that line that says relapsing multiple sclerosis. But if you look at that red line, it's been coming up, it's been creeping up, and by the time they come into our clinical care, unfortunately, we think there's been a lot of damage to the brain before they even make it into our care because it's an evolving disease process. The line we're trying to prevent might be that green line. It references axonal loss. I think of it in a couple of ways. Axonal loss is the pathophysiologic findings, but really that's a patient's, any individual's accumulating disability. So what we're trying to do in multiple sclerosis is, number one, diagnose it early. Maybe you can find it in radiographic isolated syndrome, certainly in clinically isolated syndrome. Treat very aggressively. Take that red line that's starting to creep up, bring it way down with our anti-inflammatory immune modulating treatments, and subsequently change the slope of that curve of the green line. Hopefully flatten it so that if you're diagnosed at 25, you're 85 and you still don't have any accumulated disability in multiple sclerosis. So I know this is a really busy slide, but I really like it. There's even nuance within the slide. But that's the idea that we're trying to achieve in multiple sclerosis, is diagnose early, hit hard when appropriate with our treatments, and change how these people are living out their 20, 30, 40 years of multiple sclerosis. Any questions, comments on the slide or those ideas? And I'll keep moving. Here's our treatment. Busy slide, especially for residents. I would put essentially no brain power into memorizing this slide. Even our neurology residents that come to our clinic for a day or two, this is, I think, overwhelming to try to learn something like this. I'm going to make a few points about our treatments, and you may recognize some drugs that are up there. But my main points are, look at the years. So we really did not have effective treatments for preventing disability in multiple sclerosis until the early 1990s. We have Copaxone or glitiramer, and then a constellation of interferon therapies. And those are the mainstays of treatments in the 90s, 2000s, with one little interruption, which is Tysabri in about 2004 and 5. Does anybody know the Tysabri story? Anybody know what happened on Tysabri? So PML, lots of deaths. Drug got released and then had 12, 15 deaths from PML. The drug's pulled from the market because you got to figure it out, right? Well, the multiple sclerosis community was really aggressive with the FDA, saying we're watching our lives get worse on interferons, on glitiramer acetate, Copaxone. We want this drug available. Within just a couple of years, it came out with a REMS program, a really aggressive, close monitoring program to try to risk stratify people, pay attention to who may or may not develop PML. We still have a number of PML cases related to Tysabri dosing, but at least we know some of the science behind it. Tysabri is also one of our strongest drugs. So as we interact with our patients, if they're getting worse, think about cancer. Think about some rheumatologic diseases. Got a risk-benefit discussion, and a lot of people still use Tysabri even if they have risk of developing PML, which is about a third fatal. Now pay attention to the years again. So I finished residency soon after Tysabri was re-released. I'm in private practice in Evansville on faculty at IU as a clinician. But in private practice, I'm taking care of a lot of patients across the board. And all of a sudden, what happens? See what you 2012, 13. All of a sudden, we got 3 new drugs that hit like gangbusters. To be honest, I'm a fairly decent neurologist, I thought. And these drugs came out so fast with so much demand from the multiple sclerosis community, I couldn't keep up. They're new drugs, new mechanisms, new side effects. Kind of scary when neurologists are pansies, to be honest, with our treatment sometimes. We're very risk averse as a population. So I was sending a lot of people to a multiple sclerosis clinic because it's kind of hard to learn 3 new drugs within a short amount of time. That's when my interest in MS started to grow because now we had options. A lot of these medicines are shots. So the interferons, hexams are all shots. And we're coaching our patients to just keep giving themselves shots, even though they're clinically getting worse. To be honest, it wasn't a whole lot of fun. When they're getting worse, you're saying, well, keep doing your shots, keep doing your shots, keep doing your shots. But now we have 3 new options for treatment. So actually, it's fairly exciting. Follow that ahead, and again, we get a constellation of medications coming out, 2013, 14, 15, 16, 17, and maybe 2 new drugs this year. We don't know for sure. Multiple sclerosis treatment has changed dramatically in the last decade. Many of these drugs listed down low, we think of as being highly efficacious compared to some of the older medications. Those older medications still work. So all of these drugs listed up there, except for mitoxantrone, are still used in our patients today. Any questions on that? Very busy slide. I'm going to transition to an idea called NEDA, no evidence of disease activity. So this is applied not just in multiple sclerosis, but again in oncology practices, sometimes rheumatologic practices. NEDA in multiple sclerosis is measured in 3 ways. And these are the ways the drugs are approved through the FDA. So on any therapy, our goal is that there's no MRI changes. So even though somebody may clinically be doing very well on whatever medication, we do monitoring MRIs of brain, cervical spine, sometimes thoracic spine based on that patient's story. Typically yearly, somebody's more ill, 6 months, or if we change therapy, maybe at 6 months. But even somebody who's clinically doing very well, I don't find any changes on their exam, they're happy on their therapy, we get MRI scans. Unfortunately, every flare of multiple sclerosis doesn't cause clinical symptoms and doesn't cause objective symptoms that I can find on my exam. Unfortunately, there's 6 to 10 times more MRI changes than we see clinically. So again, somebody can be cruising, a young mom, older father, whatever. We get an MRI scan, and we can see all kinds of new spots compared to a year ago. That suggests that even though they're clinically doing well, we're losing brain, we're losing spinal cord, and eventually that's going to catch up with that patient. So we want to change things, right? Somebody's failing your treatment, you want to change things. No evidence of disease activity or NEDA suggests there's no MRI changes. I've already kind of suggested it also, but they don't have any clinical changes of their body. And doing a pretty decent exam, fairly detailed neurological exam, which I think medicine people should be able to do, but we can talk about that behind the scenes maybe. I don't want to find new deficits on their exam. So there was a study, you can see the years, 2000 to 2005 into 2007, following neurological patients or following multiple sclerosis patients on whatever treatment they were on. Achieving NEDA is really hard. So you see it 1 year, 2 years, and 7 years, just gradually falls off on how many patients are successfully treated with no evidence of the disease being active. So at 7 years, 10% of patients have no evidence of disease activity. It's a little bit disheartening, but then we look at the statistics on their disability. Obviously, less disability is going to happen if there's no evidence that the disease is active. However, even patients that were incompletely controlled, they didn't meet NEDA, those who were clinically inactive or have NEDA at 2 years really have a very good prognosis moving forward. So that kind of becomes some of our goal, is we've got to choose a therapy that works, monitor them, and if we can get that patient 1 or 2 years, it at least makes me feel better that we're now looking at 10 and 20 years of probably doing much better than if at 1 or 2 years we're already seeing MRI changes, already seeing accruing disability. Another point I'd like to make about this slide is look at the years, 2000s. Remember what treatments we had then? We had 3 treatments, Copaxone, interferons, and then Tysabri came on late in the ballgame. These studies haven't been done with our new treatments that we think of as being much more efficacious. Now, in individual trials, such as with stem cell therapy, with some of these more advanced treatments, part of the monitoring those trials are how many patients achieve NIDA, but it's over a short amount of time. I'm going to mention stem cell, again, it's off-label, but we think that with stem cell treatments for relapsing multiple sclerosis, potentially 80%, again, I'm a big picture kind of person, potentially 85% of patients in those short trials met criteria for NIDA. This is potentially a huge, efficacious treatment. We just don't know about the durability, will it last, and obviously side effect then comes up quite a bit. I guess that first point is kind of what I referenced. You need it at a short interval. Did predict disability, even compared to those less than 10% that still had NIDA at 5 years. Again, any questions, any thoughts? So on into how we apply this to the treatment of any individual with multiple sclerosis. So kind of the standard treatment that I think a lot of us are trying to squash is diagnose multiple sclerosis, start a drug, again, with neurologists inherently being risk averse, starting probably with the safest medicine that that person is most comfortable with. So in today's world, it would be considered leterumor or the interferons. They have a name of platform therapies, which many of us in the multiple sclerosis world want to squash that idea also. Insurance companies like the idea because there's less cost to some of these medications. However, I'll throw it out there, these drugs are stupid expensive across the board, so the money saved is not really that significant. The idea with the first treatment strategy is start a medication, see what happens, and under our watch or neurologist watch, see them in the clinic, do exams, get MRI scans. If they fail that drug, you transition to therapy 2. Same idea, start that next medication, monitor, pay attention. If they fail that drug, transition to therapy 3. So it's sort of an escalation therapy, if you will. Start with the safest medication. If it's not working, go to the next medicine. If it's not working, now let's pull out our big gun. I'll just compare that to the second induction and maintenance or an induction approach. I think the brain and spinal cord is important. I think many of us in here probably agree. Once you're diagnosed with a disease, I'll reference that slide I showed you before. By the time you're diagnosed, unfortunately, there's already a lot of inflammation. There's probably a lot of brain changes that we can't undo. So once somebody's diagnosed, 25 years old, 35 years old, 45 years old, they're already starting behind the ball. The idea is then hit hard. Use one of our big gun drugs, hit it hard, get the disease under control, and then take a step back and see, do we want to keep our foot on the gas pedal, or should we back up and see what happens once we've hopefully squashed the disease or really taken the inflammation way, way down? This is an idea that a lot of us like, but of course every individual, every patient also has their risk tolerance to weigh into the equation as well. I'd say many of us in the multiple sclerosis world prefer that idea, second one on there. I don't know if we have rheumatology here, people interested in rheumatology. Oh, recruit some rheumatologists, by the way, if you know anybody. This is really where rheumatology went 15 years ago. We're behind the ball in neurology. Rheumatologists did the studies, proved that hitting RA hard, hitting lupus hard, works better than starting piddly. Oh, they failed that. Let's go to the next medication. Oh, they failed that. Go to the next medication. So rheumatology is advanced compared to multiple sclerosis, or they've proven it scientifically. So they're using these big gun drugs early in the disease course and probably changing how patients end up in the end game. Combination therapy doesn't work. Anytime we use 2 of these medications in combination, the outcome defaults to the stronger of the 2 medications. So we don't use these medications in combination significantly. And then personalized therapy, we don't have in multiple sclerosis right now, as far as picking the drug that works for that individual. The comparison I sometimes talk to with patients is in oncology. If you have colon cancer, you follow it up with what's the cell markers, what's the genetics, and then pick the drug off the shelf that is the exact target to that person's cancer. Multiple sclerosis is different in different individuals, which is why some drug may work in person 1, but may not work in person 2, and then the opposite of that. A different drug may work in person 2 and not work in person 1. I think I have a slide on it, but I'll mention it right now. We're looking for biomarkers. We're looking for genetics. We're looking for cell analysis so we can pick the drug off the shelf that directly targets that individual's specific flavor of multiple sclerosis. The personalized strategy, I actually think we're a long ways from achieving that, but there's people, again, working really hard on identifying it. That's the slide I was thinking. Nothing terribly remarkable on that slide. All right, any questions? Any thoughts? Yes? Correct. Yes, the question is, this isn't just inflammation, it's demyelination, and this follow-up is how are we remyelinating, I guess would be to summarize. Yep, so the question is, are we able to then fix the demyelination and remyelinate? Is there? No, not right now. Correct. So the idea is if we stop the damage, the natural healing process, which brain actually can adapt, it occurs, but it's definitely incomplete. There are clinical trials right now on 2 molecules trying to induce oligodendrocyte activity, remyelinate damaged areas. There are actually injection stem cells with oligodendrocyte precursors. Those trials haven't been published. So it's in human models now, so we have some benefit in mouse models to try to encourage oligodendrocytes to become active and remyelinate. It's ongoing right now. Great question. Any other questions? Again, I prefer a discussion to a lecture. All right, back to the long list of drugs. And again, for those who are coming in, I wouldn't try to memorize any of these medications, but just the idea. I'm going to go back 2 slides, just get my brain lined up again. We're sort of comparing 2 different ideas. An escalation approach or a hit hard, keep your foot on the gas pedal until appropriate, and potentially back off. So that's kind of where we are in the talk. Here's our list of drugs. Every drug has different efficacy in population studies. Every drug has different side effects. And we have to weigh where the patient is right now. Where does that patient want to be with regards to their life? What is that patient's risk tolerance? And then where do we think they need to be with their multiple sclerosis treatments right now? And then it's a discussion with the patient on trying to pick the most appropriate drug for their situation today. Now, insurance companies weigh in quite heavily on that decision, even if we come to a conclusion. So that's some of the things that we battle with in our multiple sclerosis clinic. So I'm a big picture kind of person because my brain gets scrambled when it comes to data and numbers. So again, that list has all the drugs in it. In the population studies, we do think of them as some being less effective than others. So this is how I kind of shelf them. Now, I will, before I comment on the efficacy, any drug could work really well for any individual. That's where we need a personalized approach so we can pick the right drug for them and maybe not expose them to the risk that may be unnecessary. So a multiple sclerosis patient across the board averages about 1 clinical relapse per year. So this goes back to the studies in the 70s, 80s, 90s. So about 1 clinical relapse per year. However, there's, like I said, 6 to 10 times as many MRI changes than clinical relapses. The drugs listed across the first column seem to cut relapses by about 1/3. Okay? It's good, right? It used to be good because that's all we had. In today's world, I don't know if it's extremely good. So you come to that middle column. The drugs listed there seem to cut relapses, clinical relapses, and MRI changes by about 50%, give or take a little bit. Gilenya may be up there a little bit more over Tecfidera. Still, that's good. It's at least better than the third. But still, that means many patients are failing these therapies. Then come to that third line. These are high efficacy therapies right now. Tysabri, Lemtrada, Ocrevus. Mitoxantrone has gone the wayside because we had too many fatalities, so we don't use it in the world anymore. So these drugs are high efficacy therapies, 2/3 reduction. That's better, right? But still, that's a lot of patients that are failing these medications. So we're trying to be aggressive with these medications to get them as healthy as possible, but there's a discussion on risk. Definitely as you come down this slide, the risk really does climb substantially. I will comment, Lemtrada and mitoxantrone, that's not really used today, are potent chemotherapy medications. Lemtrada is alemtuzumab. There is a possibility for multiple sclerosis remission. It's a word that's loosely used in multiple sclerosis. Nobody's strongly claiming it. The way we dose Lemtrada is first year there's a dose for 5 straight days. They don't get treatment until the second year, so sort of that 1-year calendar anniversary, get treatment for 3 straight days. And in the clinical trials, that's the dose of the drug. I think of it as a control-alt-delete on the immune system. It kind of brings the immune system down, lymphocytes down. The repopulation of cells seems to be less pathologically driven towards brain and spinal cord. The clinical studies are following patients out 6 years, 8 years, and a number of those patients have had no other disease-modifying therapies at years 6, 7, and 8. So those drugs may be able to induce sort of a remission state in multiple sclerosis. However, with that comes risk. So back to the idea of how we think about treating our patients. Again, just a reference to an earlier slide. The Treat MS clinical trial, we're a site for, we haven't enrolled anybody. So let me just tell you the idea since people are here. We don't know which strategy is best. We think we're going to follow in the rheumatology literature that you want to hit hard, hit early, put your foot on the gas pedal, bring the inflammation down, flatten the curve of potential disability as they live their life at 10, 20, 30, 40 years, but we haven't scientifically proven it. So even though a lot of us are seeing really good outcomes with our high efficacy therapies early, insurance companies aren't always on board. And they have their right. They want to see the science that shows we're going to use a drug that costs $80,000 to $100,000 a year versus one that's $40,000 or $50,000 a year. I kind of get it. It makes sense from a financial standpoint. So this clinical trial, headed up by Johns Hopkins, is trying to get the data behind strategizing people into high-risk disease, low-risk disease, and then higher efficacy versus lower efficacy therapy, and potentially get the science behind it so that we can prove our rationale for using more aggressive, more potent medications early in the disease course. Kind of transition here. We need help taking care of multiple sclerosis patients. They're actually fairly complicated sometimes. Life expectancy is near normal. Kind of looked through a number of studies just seeing where it is, and we're at 6, 7, sometimes 10 years less life expectancy. This is also before some of our more efficacious medications, which means what are these patients going to die of? Normal stuff. Multiple sclerosis shouldn't take my patient's life. They may have some disability, which puts them at risk for some things, but they're going to die of non-multiple sclerosis diseases, which you guys are all familiar with. Not to list things that kill us all, but we all got to go at some point. So we need good medicine doctors, we need good dermatologists, etc. We need people helping taking care of these patients. I will say with our clinic hopefully growing and expanding, and under the hospital's wing, we need all of our patients to have a good internist, not just a lazy internist. We need medicine doctors that are on top of it and not assuming that everything is MS. We take care of a lot of stuff that is medicine, but these patients need good primary care doctors. They need good cancer screening, especially on some of these medications. Those I's need dotted, those T's need crossed, so our patients need good medicine care. I don't know how to do cancer screening anymore. Probably should. I should put some brain power into it. But really what I need is good help from my peers. Unfortunately, many of my patients over their life are going to accrue lots of different symptoms. And I have them listed here. Again, we can talk through it. Everybody knows this kind of stuff. Many of them are going to have urological issues. Many of them are going to have pain issues, spasticity issues. I need good physical therapists. I need occupational therapists. I need good wheelchair evaluators. Or not my patients need these resources. Urology is important. Ophthalmology is important. I'm kind of preaching to the choir here, but these patients need a lot of help. Then we're using these potent, weird medications. The complications of these medications, it's my job to pay attention and to recognize, but I also don't have the best training in managing thyroid disease. I'm a decent infectious disease doctor when I know I need to call the infectious disease doctor. Unfortunately, PML happens. Unfortunately, cryptococcal meningitis happens. Unfortunately, disseminated zoster can happen. We can get some complications where we need help. With these potent medications and hopefully better neurological outcomes is going to come risk of these other problems. And we as a team are going to need to take care of these patients, hopefully more in the outpatient settings. That means they're healthier, but unfortunately sometimes in the inpatient setting. So we need to have a team approach available, which I think a university system is rightly set up to do. We just need to have active communication. My plan isn't to talk about the drug specifically. Some of these side effects listed up here are very drug specific, but I think the idea is that we need a multidisciplinary approach, not just in a single multiple sclerosis clinic, but across a system. That's kind of the talk. Everybody can take a breath and realize we all have work to do, and it's not going to be that long. So look up here. These are my goals. We at least have some understanding of. Fairly simple, kind of big picture stuff, maybe with some specifics. That's all I have. I am open for questions here. You're open to come to my clinic anytime. But that's kind of all I have today. I'll pull the slides. So the question is, as a non-immunologist, how do you pick which drug works? I think even our super smart immunologists, we still don't know which drugs work. It's a really individual decision. I teach residents, and I think it's a hard decision to come to. It's not cookbook medicine. Insurance companies are looking for an algorithm. There are proposed algorithms, but even those fall apart fairly quickly when you come across a patient with more yucky disease, and we don't want to use an algorithm. We just don't have the science behind it. I will say in the clinic, the way I think through it, it's a detailed history. I try to learn about the individual's lifestyle, not just who they are neurologically and on their scan. What are they trying to achieve? Where do they work? What's their work necessitating? I'm trying to gauge, without asking specific questions, where their risk tolerance is. I'm sure people in here are familiar with the word risk tolerance. It's in the psychological literature, it's in the gambling literature, it's in the medical literature. I'm trying to gauge somebody's risk tolerance to pick the right drug for them. As I'm interacting with a patient or staff is interacting, I try to break it down to 2 drugs. One, that are going to be good for that patient. Secondly, I think the patient are going to pick between. I usually try different formulations, either an oral medication versus an infusion, maybe an injection versus an oral medication, to try to pick a drug from 2 different ways of delivery. And I talk to that patient about those 2 drugs in pretty good detail. Obviously, if they're weighing in, I tell patients that it's your body. I'm your doctor, but it's your body. Whatever we pick is what's going into your body, so you need to be comfortable with these things. And to be honest, sometimes I'm watching the patient see where they light up or where they shut down. And I can mention Tysabri, highly efficacious, been around since the mid-2000s, but there's a risk of PML and death. I can see patients just go, why the hell would I do that to myself? Even when I'm talking about that brainstem relapse is really serious, that patient's risk tolerance is just averse to Tysabri. So it's a hard discussion. We don't have an algorithm that is approved nationwide, so it's a very individualized conclusion. That's a long answer, though. Sorry about that. Yes, sir. Yep, so questions on vitamin D and multiple sclerosis. There is a lot of literature. We don't know for sure where it's going to go. It looks like for sure low vitamin D is associated with the diagnosis of multiple sclerosis, especially in pediatrics. We don't yet know that supplementing vitamin D after the diagnosis results in fewer relapses or less disability. But my approach is, why not? So all of my patients should be aggressively supplementing vitamin D in addition to treating the MS with a disease-modifying therapy. I think the science isn't yet to where we know it's going to help. I have read papers on supplementing all humans before the age of such and such may prevent a third of cases of multiple sclerosis. I've seen those papers. I don't know that I buy in that strongly at this point. My kids aren't on vitamin D, so maybe they should be. It's an evolving, very interesting part of MS literature. Yes, sir. So the main comment is from Saskatchewan, Canada, the highest incidence across Canada per capita. So is there a hotspot in the United States? So this references the epidemiology of multiple sclerosis. It seems to increase as you get away from the equator. So Canada is farther away than Jamaica. Why Saskatchewan might be different than Ontario, I don't know. But there is a higher incidence of multiple sclerosis as you get away from the equator, both north and south. And really some of that is driven by where you grow up. The first, prior to puberty for sure, 12 years of life, where you grow up seems to set that incidence of multiple sclerosis. So if you grow up in Saskatchewan, if I might reference you, live 12 years there, then move to Jamaica, your risk really follows that of a Canadian. We do think vitamin D plays a role, but we don't know for sure. We do think that infectious disease might play a role, but we don't know for sure. Some of that is actually going away. So the epidemiology in the last few years seems to be lessening that north-south latitude. Wait, that's longitude, isn't it? That north-south difference seems to be, which is it? Okay. I don't use these words all the time. It seems to be decreasing, and some of the ideas are more aggressive worldwide vitamin D supplementation in fortified foods, but nobody knows that for sure. Yeah. So questions of extension of vitamin D, do we monitor and do we have a certain target? Sort of. So less than 30, I'm paying attention and supplementing aggressively. I would say I have a goal of 50, but I have other goals also that I address more aggressively than trying to get vitamin D up to 50. Yes, I'm supplementing with a goal over 50. I supplement, all my patients I tell 5,000 units a day, in addition to try to get your son some exposure in the non-dangerous times of the day. And then somebody that is low, say 19, 17, 50,000 units a week for 12 weeks. I would say my goal is to then follow that up because there's a lot happening. I would say I'm inconsistent in always rechecking the vitamin D. I haven't yet. Across the board, I haven't yet. I have had patients that get up into the 120s and 130s, and I have them kind of back off. And I do tell patients, in supplementing your vitamin D, make sure you're not getting the chews that have a ton of calcium also. Yeah, so again, referencing a doctor in Brazil with amazing results with vitamin D. I think it's yet to be seen. I think pharma would like that not to be the case. Yes, sir. So great comment, and hopefully people can hear, but trying to identify the patients that are going to go on to have early disability versus those that are going to go 5 and 10 years between attacks and live a fairly normal neurological existence. We don't know. The Treat MS trial might try to identify some more objective findings. Biomarkers are a buzzword in multiple sclerosis to see who has certain biomarkers, but then we have to identify who does that match up with that seems to be more active versus less active. So right now, I would say we look for a few things. One is male gender seems to have worse MS over time once diagnosed. A motor relapse, brainstem relapse, a spinal cord relapse tends to suggest this patient's at risk for early disability. The lesion burden on MRI, the total number of lesions isn't necessarily predictive. Where those lesions are does seem to be predictive. So brainstem, cerebellar, peduncle, spinal cord. So the way we think is automatically linking those into these are the patients that are likely at higher risk of disability. Your question is great on where are they in their inflammation state. I'll just reference a slide just because it's busy, but it makes sense. So since essentially all of our treatments are anti-inflammatory or immune-driven, we catch a patient out here, put them on our biggest gun drug because we think it's going to work, well, the target might already be gone. That inflammation, they may not even have active inflammation. They may be more degenerative. And we wouldn't want to put those patients on our highest efficacy drugs and think we're doing a good job and just expose them to unnecessary risk. But we don't know right now. The biomarker world doesn't seem super, I think we're a number of years away from having active. Absolutely. Right. Yes, sir. Mhm. Yes, the references in oncology are using immune boosters to target malignant cells. I don't have any knowledge in a patient with multiple sclerosis. As you know, some of these chemotherapy treatment, or not chemotherapy, immune boosting medications result in autoimmunity, demyelinating both centrally and peripheral. We've taken care of a number of patients that have had neurological complications, immune complications from these medications. I have not seen, either in my experience or the literature, patient with MS that gets, say, melanoma, goes on an immune medication, what may happen. So no, I don't have any experience or knowledge of the literature in that. Yeah, so the question is on the JC virus relationship to PML. So unfortunately, 2004, 2005, when Tysabri came to the market like gangbusters, a lot of PML happened. Drug was pulled away, scientists look into it to figure out what's going on, re-released fairly quickly with a monitoring system in place. We screen patients that might go in high efficacy therapy for the JC virus. It's now to a number, so there's a JC virus index, and that number can predict negativity, positivity, and gray zone in the middle. The graphs on all the PML cases directly linked to Tysabri do suggest where patients are at the most risk. Patients are positive around the 0.9, 0.5 range. This seems like PML